The third case today is 60-year-old female with pancreatic duct stricture. The patient's chief complaint is upper abdominal pain. She has history of acute pancreatitis a year ago, which cause was unknown. MRCP shows pancreatic duct stenosis at the head of the pancreas and slightly dilated duct from the body to tail. ERCP cytology of pancreatic juice and EUS-FNA was performed half a year ago, which showed no evidence of malignancy. Patient was scheduled for repeat EUS-FNA. The operator is Dr. Robert Hawes in the endoscopy room.
Okay, well, good morning. Philip, can you hear me?
Yes, good morning.
Good morning.
Yeah, we can hear you.
So this is a very, very interesting case, and I am very happy to have Takao, Toy, and Dr. Ryozawa to help me to figure this out. I find the history very, very interesting. So it's a lady with the two acute episodes of pancreatitis, but probably, in fact, represents a chronic relapsing pancreatitis. She's had an ERCP showing a very irregular pancreatic duct with a narrowing in the head. She has an MRCP with the same finding, a little bit of dilation upstream of a narrowing in the head. She's had an ERCP with juice aspiration, which is a very common way to evaluate patients in Japan, and it was negative for malignancy. She's IgG subgroup 4 negative, and the Takao tells me that the majority of patients with autoimmune pancreatitis in Japan are positive for IgG4. She has a negative family history for pancreatitis, so it's somebody that has chronic relapsing pancreatitis for no apparent reason. So I'm...
Rob, so
yes.
what kind of echo endoscope do you use now?
So for me, for the pancreas, always the linear. Even if FNA is not a possibility, for me, the best imaging is now with a linear. So this would be the instrument of choice.
Okay, in other words, so when do you use radial EUS?
So radial EUS I use for efficiency and for the anus, for anal canal evaluation, and for luminal imaging, for the esophagus sometimes, for the bile duct if I just want to see if there are stones. But for me, more and more, it is the linear.
Yeah.
So it is important for me when I demonstrate EUS, I want to leave the examination and that everybody in the audience understands a systematic approach to imaging. This is my most important role here, I think. So you can see on the endoscopic view that I'm starting at the GE junction. You can start anywhere you want to image the head, the body, the tail, but for my purposes, I will start at the GE junction. So you can see endoscopically that I'm at the GE junction. So I will switch now to the endosonography. And when you start at the GE junction, always the liver will be the first organ that you image. I torque. Oh. Okay. So I will torque clockwise. Okay, clockwise off of the liver. And as you torque clockwise, you will encounter the aorta. And between the aorta and the transducer will be the crura of the diaphragm. So once you see the crura of the diaphragm, I advance the scope and I torque gently clockwise and counterclockwise. When the crura of the diaphragm disappears, you should begin looking for the takeoff of the celiac artery. So here is the takeoff of the celiac artery. You should follow it. until it bifurcates. And you can very easily see the bifurcation. So once you get to the bifurcation, you should go down on the up-down, so big wheel away from you just a little bit, and advance the scope. And from this point, you will almost always encounter the pancreas. So the pancreas is right here underneath the transducer. So now I have the pancreas in very good view. If I torque counterclockwise, then I will follow the genu of the pancreas. So it heads down now toward the head of the pancreas. If I torque clockwise, then I will go toward the tail of the pancreas. So now I'm oriented to the pancreas, and now it is time to evaluate the gland itself. And for me, what stands out are these echogenic strands that are running through it. It is not a homogeneous salt and pepper, even kind of an image. So I see echogenic foci, and I see echogenic strands to begin with. I also see what I call railroad tracks. So here is a railroad track. So very echogenic structures running in parallel. These represent visible side branches. So I have echogenic strands, I have echogenic foci, I have visible side branches so far, and I'm beginning to believe that the main pancreatic duct will be irregular in its contour. So if I can isolate that, so I'm torquing clockwise. As I torque clockwise, you will see, you can freeze it just for a moment. Freeze, yeah. So here is the kidney. Okay, so here is the kidney. And this sort of artificially separates the body of the pancreas, which is to the left, and the tail of the pancreas, which is to the right. So I've lost the pancreas just a little bit, so now I'll retrieve it. This is the pancreas here. I'm just torquing more and more clockwise. And here is the pancreas now sort of going out toward the tail. It typically trails off as it goes toward the spleen. Here's the kidney again. Pancreas on top of the kidney here. So I haven't yet found a good image of the main pancreatic duct. I suspect that it will be very irregular if I can find it. But I believe that I am building a picture of the EUS supporting the findings on the ERCP, which is that of chronic pancreatitis. This is not a normal gland. It's got a very irregular outer border to it, which is sort of a finding of lobularity. There are 9 total criteria that I look for, and I found at least 5 of them so far. So I believe that this gland is consistent with chronic pancreatitis. So I want to now go to the head of the pancreas. So I will go to the endoscopic image now, and I'll inflate some air. I'll advance the scope just like I would with ERCP. And there is the pylorus. I'll advance through the pylorus, tip down on my up-down, and now I want to visualize in the foreground the apex of the duodenal bulb. So this is my next station that I want to image from. So now if we can go to the, can we go to ultrasound as the main part of the screen? Okay, thank you. So now I'm in the apex of the bulb, and the critical sort of structure that I'm looking for now is the portal vein. Can you freeze it? Thank you. So here is the portal vein. So this is the hallmark or the major structure that you need to identify from the apex of the duodenal bulb. Once you find the portal vein, then you can do the tracing necessary in the head of the pancreas. So here is the portal vein. We can put flow on it if you wish. But between the portal vein and the transducer, from the apical position, always will be the bile duct. So here is the bile duct, okay? Between the portal vein and the transducer when you're in the apical position. So the reason that I wanted to look at the bile duct is because of the possibility of an autoimmune process. I want to see if the bile duct is normal or abnormal. And I will mention that the alkaline phosphatase was normal in this patient. So my suspicion of a cholangiopathy in conjunction with the chronic pancreatitis was relatively low. You can see here the bile duct typically has sort of a 3-layer wall to it. This wall is maybe a little bit irregular, but I don't make too much of this bile duct, and I'm supposed to take more pictures, so there's a picture. Now, from this position, if you torque counterclockwise and tip down, you will follow the bile duct toward the liver. Okay? So now we're following the bile duct, and there off to the left is the liver. From the apical position, if you find the bile duct and you torque clockwise, you will follow the bile duct down toward the ampulla. And now it's going into the head of the pancreas. So here is the head of the pancreas, and here is the bile duct as it enters the intrapancreatic portion of the bile duct. And you can see here that it becomes narrowed. Freeze it. And you can see this area of fibrosis, or I should say of echogenic material. I cannot prove it, but it is my impression that a halo, an echogenic halo around the bile duct in the intrapancreatic portion is another criteria for chronic pancreatitis. So you can see the bile duct here narrows as we go through the head of the pancreas. And I think, again, is another criteria for chronic pancreatitis. Now, from this view, we can also follow the pancreatic duct. And I believe the pancreatic duct is here. If there is no divisum, then we should see the bile duct and the pancreatic duct insert in the same place where the duodenal wall is. And so here the bile duct is coming down like this. The pancreatic duct is coming up like this. So I think they're sort of headed for the same location. Although here we lose the pancreatic duct to a certain extent. If you can freeze it. So here we're beginning to lose the pancreatic duct just a little bit, and I haven't been able to follow it here very well. You can see these echogenic strands, and this area looks like the rest of the pancreas as well. So now I do not see any mass here, so I don't see anything that looks different. It all looks the same in terms of the echogenic strands, the echogenic foci, the lobularity. This gland is all sort of the same. But I now want to go to the third position for the head of the pancreas, because this is actually, I think, the most important for this particular case. So if we can go to the, thank you. So now we're going to go around the apex of the duodenal bulb. And I call this the kissing maneuver. So we basically try to make a general image or find the papilla. And I think the papilla is there at the 12 o'clock position. I then come up on my up down. And then if we can go to the ultrasound. Thank you very much. So now from the kissing the papilla position, one thing that I look for is the aorta. And so I'm going to pull back here just a little bit. And I'm looking primarily for the aorta. And if I don't find it, I'll do this maneuver again. So that's the IVC, I think. We can, or maybe that's the aorta, huh? So pulse wave. Okay, so that's the aorta. Okay, so once you find the aorta from the kissing papilla maneuver, then you torque clockwise. And then we need to fix our eyes on this area here. The pancreas should come into view in this area here. So I'm just slowly pulling back now and torquing clockwise. Okay, so there's the pancreas coming into view in the upper right-hand corner. I'm torquing over. So there's the pancreas. There's the uncinate process, the deep part of the pancreas. And then I believe that coming into here will be my bile duct and my pancreatic duct. So I'm just sort of slowly coming back. At this point, torquing a little bit counterclockwise. Here I think is a pancreatic duct. Here, I think. So this is an important image because I can trace the pancreatic duct. I did this off camera. I can trace the pancreatic duct until it disappears, and I did not find a stricture there. So I need to go back and redo this, this maneuver. Thank you very much. So this is not, this is a part of ultrasound. You don't always get the exact imaging that you want all the time, and you have to repeat a particular maneuver. So that's what I will do here. Get back into the second portion of the duodenum, right on your right, left, pull back, find the papilla, and redo the maneuver. So up on your up, down, kiss the papilla, and then go back to the ultrasound. And then I will try this maneuver again. So there's the pancreas coming into view in the upper right-hand corner. And I think
So, Dr. Hawes?
yes, of course.
Dr. Hawes? Hi. Can we briefly go back to Dr. Inoue's room because he's ready for showing something to us? Can we?
Can you
and
stay
then
with
we'll
me
be
for
back?
just 1 second? Just 1 second, because I
Okay,
think I
no
have the
problem, thanks.
pancreatic duct here, and I just wanted to show you that this pancreatic duct disappears, okay, right in this area here, but in fact I do not see any mass. I do not see any mass here. So from my perspective, right here the pancreatic duct disappears, but it's not associated with any mass. And so I don't feel, Takao and Dr. Ryozawa, that this is necessarily needed to do FNA. I see a uniform chronic pancreatitis. I think this is a fibrotic stricture.
Yes.
I don't see any associated mass.
Yes.
So I think it is a case of idiopathic chronic pancreatitis.
Totally agree.
Do you agree?
Yes.
So the one question is, if this is suspected AIP, autoimmune pancreatitis, at that time, so the histological sampling is one of option
Yes.
to diagnose
Yes.
AIP.
Yes.
For example, immunostaining IgG4 or something.
Yes.
So for the purpose of that, so do you like to do USFNA?
So I would do USFNA, but you need a core specimen for autoimmune, and I would do it only if I see an inflammatory mass. I do not like to do it if it is a uniform chronic pancreatitis without an inflammatory mass. I'm reluctant to do that.
Okay. Thank you.
Okay. Okay, thank you very much.
Thank you very much.